Thank you, sir. Listening to Sumit sir has always been a pleasure. So you sharing the stage with him and speaking after him is a big responsibility. I'll try to do justice as much as I can. Reshma ma'am, my head of the department, was supposed to be here, but she can't come for some circumstances, some ill health. So let me do justice to the topic as much as I can. Let's start a discussion on the abdominal catastrophe in intensive care. So we all know there are mainly these four situations that we come across: paralytic ileus, toxic megacolon, Ogilvie syndrome, and mesenteric ischemia. We'll be discussing these in detail. Let's start with the case. A 78-year-old man with history of hypertension, diabetes, admitted to your ICU following open reduction and internal fixation of leg of femur fracture. On the second post-op day, he developed abdominal distension and no passage of stool and flatus. He is afebrile, hemodynamically stable, labs were fine, but just X-ray abdomen shows distended bowel loops. So the differential diagnosis, of course, he's an elderly man. We would all think of paralytic ileus in the very first place. So how do we define paralytic ileus? It's a functional motor paralysis of the digestive tract secondary to the neuromuscular failure, which involves the meningeal and the Meissner's plexus. So basically, in simpler terms, the intestine fails to transmit the peristaltic waves, which results in functional obstruction, and gas and fluid is collected in the intestinal lumen. In the post-operative period, the ileus is common because it is the inhibitory alpha-2 adrenergic reflexes which are triggered by the stimuli. Of course, this is mainly for abdominal surgeries, but otherwise also in any surgical patient, this could be common, and it resolves spontaneously after 24 to 48 hours. The risk factors are prolonged abdominal or pelvic surgery, delayed enteral nutrition, intra-abdominal infection, intra-op and post-op bleeding, perioperative use of opioids, factors which increase the bowel wall edema like hypoalbuminemia and aggressive administration of IV fluids, uremia, dyselectrolytemia, and retroperitoneal trauma, hemorrhage, fractures. On examination, the patient might complain of distension, bloating, and diffuse abdominal pain, nausea, vomiting, inability to tolerate the diet, inability to pass flatus and feces. On examination, we would see that the abdomen is distended and there's tympanic note all over. We investigate the patient like any critical care patient in a routine ICU. We go for our complete blood counts. Electrolytes are important. We always prefer to keep a potassium a little on the higher side to prevent paralytic ileus. Hypomagnesemia we need to look for. Creatinine and BUN levels because uremia can also precipitate paralytic ileus. And LFTs and ileus lipase we need to do just to check if there's any other intra-abdominal inflammatory process ongoing which could precipitate ileus further. On radiology, of course, the best investigation would be getting a CT scan done with an oral contrast. But it's not always possible, plus it's not always necessary to do this added test. We can just get a supine or an upright abdominal X-ray. Out of the two, again, the upright X-ray would be much more better. But then at times we have patients who cannot be taken for an upright X-ray. So we might have to just go with a supine abdominal X-ray. So this is the first picture that we see. This is a supine abdominal X-ray of a patient with paralytic ileus. As we can see, these are the dilated bowel loops and these are the hostrations. Looking at the hostrations on the supine X-ray is important because if the hostrations are present, it's most likely a paralytic ileus which would settle in a day or so, 24 to 48 hours. But if the hostrations are absent, it is most likely going towards toxic megacolon. So we need to be very vigilant about this, and toxic megacolon would definitely need much more aggressive management. And this is an upright X-ray abdomen. It just shows multiple air fluid levels. So we might confuse with if there's an intestinal obstruction or just an ileus. So to get a definitive diagnosis, of course, we'll need a CT scan. So this is the first CT scan, which again shows a transverse scan, which is showing multiple air-filled cavities. And the X-ray we can correlate, it has multiple air fluid levels. If we get a contrast CT done with an oral contrast, This is of the same patient, so this we can see there is some sort of obstruction here. So we can see the narrowing, we can see non-passage of the dye. So getting an oral contrast is important to differentiate between if it is just an IBS or an obstruction. But yes, in the initial part, when looking at the scenario, I'm sure we come across it multiple times. Just an X-ray would be fine to diagnose paralytic IBS. So management of IBS, we would minimize the use of opioids, maintain normal volemia, and correct any dyselectrolytemia like hypokalemia, hypomagnesemia. Start trophic feeds, clear feeds, sips of water or clear fluids. We can go for abdominal girth monitoring every 4th or 6th hourly. And once we feel that the patient is tolerating oral feeds, we can increase the feeds. Or if not, then we need to consider total partial or total parenteral nutrition. Bowel decompression can be done. We can just place a nasogastric tube and keep it on continuous aspiration. That should also help. We should go for serial abdominal examination at least every shift. Basically, that's what we say. Like throughout the day, at least 2 to 3 times, we should palpate the abdomen and check for if there's any worsening or if there's any tenderness happening, and evaluate for other intra-abdominal causes like sepsis, uremia, intra-abdominal collection, etc. So this we come across very frequently. During morning rounds, we often tend to check the bowel sounds, and then we decide if we can start the enteral feed or not. So would anybody be telling me how much time should we give to actually listen to the bowel sounds? Yeah, so as per the books, what they describe is we can go to as much as 2 minutes, and 5 to 30 bowel sounds per minute is the accepted range. If at all we are expecting any reduction, if we are expecting that the patient might have some paralytic ileus, we can even extend it to 3 minutes. So we need to do that frequently. So do we need to check the sounds before starting the enteral feed? The sounds which are made by the bowel are just an evidence of contractility, not the absorptive capacity and not the mucosal integrity. So the bowel can still borgomize while the bowel's mucosa is eroded, denuded of villi, and is swarming with translocated bacteria. Plus, a healthy intact bowel may be silent for a brief seconds that we actually listen to. So, checking the bowel sounds might not be necessary. We can just start with clear feeds, just trophic feeds, 20-25 ml per hour, and observe for the next 6 hours. If we see any distension or if we see any increase in the RT aspirate, then that's what we are worried for. Then we should look over it. So the next topic would be toxic megacolon. It is a rare but severely fatal complication of colonic inflammation. How do we define it? It is a radiological definition of total or segmental colonic distension of more than 6 centimeters with systemic toxicity. Colonic dilatation is also observed in patients with congenital megacolon during chronic constipation, but these patients are without systemic toxicity, so we cannot label them as toxic megacolon. Now, what are the systemic toxicity that we are looking for? First is, of course, the radiographic evidence. The systemic toxicity includes temperature more than 38 degrees, heart rate more than 120 beats per minute, leukocytosis, and anemia. Any 3 of these need to be present, plus any one of the following, that is dehydration, altered sensorium, dyselectrolytemia, and hypotension. So, what is the etiology of toxic megacolon? One of the common etiology in a chronically ICU admitted patient is C. diff infection, E. coli infection, amoebic colitis, and of course in an immunocompromised patients we can get cytomegalovirus colitis and all this inflammatory bowel disease as well. This is an X-ray of the toxic megacolon. As we can see, this is the dilated loop, and we can appreciate there are no hostrations present, which we were discussing in the paralytic ileus picture. So there are multiple air fluid levels in the colon. The normal Haustre pattern are either absent or disturbed, and this is usually greater than 6 centimeters. It can be as much as 15 centimeters, especially on supine films. For treatment, we go for individual treatment like management of C. diff. We give tab Vanillin 250 to 500 milligrams QID, metronidazole injections, fecal microbial transplantation or colectomy. If it is CMV colitis, we need to treat with ganciclovir, can go for laparotomy, may need laparotomy as well. In fulminant colitis, high dose steroids, ulcerative colitis would also need IV steroids. The next is Ogelov syndrome. This is colonic dilatation which occurs in the absence of mechanical obstruction, and this is confined mainly to the cecum and the ascending colon with transition near the splenic flexure. This is very commonly seen in elderly. If the diameter of the colon is more than 12 centimeter and the duration of this dilatation is increases, that means the complications would also increase further. So, etiology, there is no definite cause per se. It's mainly because of advanced stage dyselectrolytemia, polypharmacy, and poor functional status. That is, if the patient has been immobile from a very long time. So, as we can see, this is the cecum and the ascending colon, and there is a cutoff at the splenic flexure. This is more than 12 centimeters, and for treatment options, the goal of treatment is bowel decompression. So we can go for conservative, pharmacological and endoscopic therapies. We of course start with the conservative therapy of inserting a Ride's tube, maintaining normovolemia, keeping the Ride's tube on continuous drainage. Dyselectrolytemia and any other underlying cause need to be corrected. Stop medicines which impact the motility and stop laxatives in the initial hours, in the initial few days, 1 or 2 days. Ambulate when feasible, give knee chest position, and we should go for daily CBC electrolyte monitoring, again to check for dyselectrolytemia. If there is no development of signs of a complicated disease and the bowel diameter, cecal diameter is less than 12 centimeter, we should continue with the conservative approach, and the success rate is usually around 90%. So we can continue for 72 hours with this approach. Pharmacological therapy, we do it again if we've crossed that 72 hour, 3 to 4 days have crossed, the diameter is more than 12 and we've not really found any success with conservative management. We give neostigmine 2 milligram IV. We give it slowly. Of course, it has its own disadvantages. We all know it can cause bradycardia. We keep atropine ready bedside. Final, if at all there is a contraindication to neostigmine or even after pharmacological therapy the bowel is not decompressed, we can go for an endoscopic management. We can, with the help of the endoscope, we can do a decompression, keep a guide wire in situ so that we do not need to do the decompression, colonic decompression recurrently. Percutaneous colostomy, cecostomy, these are all advanced modes which we can take up if the patient does not settle after a very long time as well. So the next case, this is a very, a common case which is very lethal also. A 65-year-old man admitted in the ICU with sudden onset pain in the abdomen. History of hypertension, diabetes and atrial fibrillation. Heart rate was irregular, BP 140/90. Mild abdominal tenderness, lactic acidosis on EBG, TLC counts almost normal, amylase lipase normal, USG normal. So we find this pretty frequently. We always go for a cardiac evaluation also. It could be MI, some epigastric pain which could mimic MI or something like that. We investigate the patient thoroughly. But if at all we forget to look for the lactates, that is where we are missing on. Plus, we should never ignore the patient's symptoms. The patient might complain of diffuse abdominal tenderness, and that would help us diagnosing this. So acute mesenteric ischemia is sudden intestinal hypoperfusion, and it could be of two types, occlusive and non-occlusive. Occlusive, most commonly we see is of course arterial occlusions. There could be venous or a non-occlusive disease also. The percentage for arterial is around 70 to 80%. We can see here venous is hardly 5 to 10% and non-occlusive is also very minimal. So let's discuss arterial occlusion first. Pathophysiology, the dislodged thrombus from the left atrium, left ventricle, cardiac valves or the proximal aorta. Of course, they would dislodge, embolize, and they tend to lodge at the narrowing points. So from the abdominal aorta, wherever the superior mesenteric artery is taken off, that is a very narrow point and that is very prone to get this embolization happen. So it occurs mainly because of embolization or due to atherosclerosis as well. The risk factors for embolism is, of course, we have some cardiac arrhythmias, recent MI, aneurysm. For thrombotic, there could be history of peripheral artery disease, smokers, advanced age, low cardiac output state or a traumatic injury. What we need to keep in mind is any arterial thromboembolism, any mesenteric ischemia because of arterial thrombus, is not associated with any inherited coagulation defects. So we need not really look for all the panel of tests that we do in an arterial thrombus. The clinical features: patient would complain of abdominal pain, minimal findings on examination, metabolic acidosis plus lactic acidosis, and we would find some history of atrial fibrillation or peripheral artery disease. So this is a CT scan which is showing this is a non-calcified thrombus in the superior mesenteric artery, and this is how calcified thrombus would look. It would have a periphery rim which is much more wider than the thrombus itself. Our main treatment would be anticoagulation. That's why we need to look for this. We usually get an urgent CT angio and go for anticoagulation. What we use is heparin. We titrate it with APTT monitoring. Every institute has its own protocol. We involve the surgeons as well. Broad spectrum antibiotic, it's a questionable role, but yes, there's no harm giving it, at least in this condition. Proton pump inhibitors, we can go for a conservative management or maybe taken up for a primary endovascular technique as well. We look for peritonitis and other features. Pharmacological or mechanical thrombectomy can be done and a balloon angioplasty, but I think mostly we go for heparin infusion and then switch the patient to a low molecular weight. Mesenteric venous occlusion, it is again very rare, most commonly seen in malignancy patients or myeloproliferative disorders. The main reason of venous occlusion is stagnation of blood flow, the Virchow's triad, and vascular injury and hypercoagulability. So it involves the distal and the small intestine and rarely involves the colon. Local factors, splenectomy, pancreatitis, and other intra-abdominal malignancies. The important point is that systemic hypercoagulable state like protein C deficiency would lead to thrombosis and initiate the entire process and then aggravate it further. So this could be related to some hypercoagulable disorders in contrast to arterial embolism. Diagnosis is on CT scan. Presence of venous filling defects or absent flow in the mesenteric veins during the venous phase, enhanced bowel wall and mesenteric stranding related to edema. The bowel wall thickening would be more than 3 mm. Intestinal pneumatosis could be appreciated, portal vein gas, bowel dilatation and ascites. So for management of venous occlusion, we give bowel rest, keep the patient NPO prophylactic antibiotics to limit the bacterial translocation. Anticoagulation could be tried and exploratory laparotomy should not be delayed. Non-occlusive mesenteric ischemia, it is related to homeostatic mechanism that maintains the cardiac and the cerebral blood flow. So any low cardiac output status, first the body tries to maintain the cerebral blood flow and this splanchnic circulation is hampered during that. There is splanchnic vasoconstriction which could cause mesenteric ischemia. The risk factors are cardiogenic shock, peripheral artery disease, aortic insufficiency, septic shock, arrhythmias, administration of vasoconstrictive medicines, cocaine, ergot poisoning, and dialysis could also cause this. Diagnosis on a CT scan, here we can see there is narrowing, so the patient is more prone to get ischemia. Plus we can see these dilated bowel loops also. Here we can see this chain of flakes appearance. Again, just an exam question, chain of flake appearance is mostly described in chronic pancreatitis on an MRCP, so that is more important radiological finding. But this is also described as a chain of flake appearance or string of sausage sign. The treatment, the goal of treatment with non-obstructive mesenteric ischemia is to restore the intestinal blood as fast as possible, remove the inciting factors, treat the underlying cause, and maintain hemodynamics and monitoring. This is just a flowchart of how do we proceed. This is just what we've just discussed of how do we proceed when we see a patient with history and symptoms which suggest intestinal ischemia. So once the patient is hemodynamically unstable and there are signs of sepsis, we resuscitate, ensure good intravascular volume to prevent non-obstructive ischemia. And if there are no features of sepsis, and the patient has some abdominal complaint, we should think of plus raised lactates, we should think of mesenteric ischemia due to some obstruction, some thromboembolic phenomena, and we get a CT angiogram, and we look for if it is a mesenteric venous or an arterial thrombosis. Thank you.
Any questions?
Any questions?
Thank you, Dr. Uruchi.